Assalamu alaikum everyone. My name is Humaira Khalidi and I'm a second year medical student. Um, Today I will be giving the lecture Anatomy of Human Pelvis. This includes both Pelvis I and Pelvis II. Thank you guys so much for joining. I hope you guys enjoyed the session. At any point of time, if you guys have any question, please feel free to unmute and let me know. Okay? So this is how it's gonna go. I went through your recording, I went through your transcriptions, I went through the red file. And as a person who did ERP last year, I will tell you something that doctor, this doctor, the one who gave you the lecture, Dr. Faisal Ikram, he does not get a lot of questions from the red file. However, what he does do is he gets stuff that he hasn't emphasized in the lecture. Okay, so that's one thing that you guys want to keep in mind. The second thing is pelvis is a OSPE heavy lecture. You will find a few MCQs on this. However, you're going to find most of OSPE questions of this. Now, the third thing, I did not make a cram sheet for this like I did for GIT, mostly because this is anatomy and you guys need to know how it's going to work. So a lot of these slides, I'm going to use the slides to explain the content, but there is an app called Woka that I'm going to use to explain the anatomical figures in detail because the best thing about anatomy and the, the reason I love anatomy is because every single thing is so easy to visualize if you just have the right app. And for me, it's Woka. Okay, so now let's start. Um, okay, to begin with, we're going to talk about the components of the pelvic girdle. Now, the pelvic girdle, what are the main functions of the pelvic girdle? The main functions are structural support, protection of organs, birth canal, bone marrow source, and mobility. You're going to find out all about this, okay? Now, these are just something that you want to read in detail whenever you have the time to go through it.
But there are a few things that you guys need to keep in mind. For example, the pelvis, it supports the vertebral column and transmits body weight to both of your lower limbs. So now let's say that you have your entire upper body's weight is transmitted to your pelvis, and the pelvis, it helps in evenly distributing the weight to both of your lower limbs. All right? And then you continue to you have this thing called sacrum. I'm going to describe what it is in detail. But here's how it works. Okay, so the sacrum would have a joint which helps in mobility and it helps in weight transmission. After that, we have the pelvic bones, which help in protecting the pelvis viscera. So what is the pelvis viscera? You have your reproductive organs. You have the lower bowel. Mainly, it's these. And if you have any trauma to these organs or to the muscles in the pelvis, what's going to happen? You're going to have fecal incontinence. You're going to have urinary incontinence. You're going to have um, damage to the reproductive organs, let's say. And then you have the birth canal. The birth canal is essentially the area through which the child passes through during the delivery. We're going to go into detail in a bit. This is just an overview of the entire lecture, okay? And then bone marrow sauce. This is very important. This is the most important part of the entire lecture. What happens is um, there's two parts that you've taken until now from where you can take a bone marrow aspiration. One of them was the sternum, and this is another one. This is the iliac crest. From the iliac crest, you can take a bone marrow aspiration. And another thing is in your iliac crest, you have um, osteoprogenitor cells and or osteoprogenitor precursor cells. Now, what are these? These are cells that make bone. Okay. Now, if you want to take a few bone cells for grafting, for bone grafting, you can take an aspiration from here. You get what I mean? So you have a lot of you use the iliac crest for bone marrow biopsy and for graft harvesting. Then you have the mobility, and in mobility, the pelvic joint allows limited movement because of these ligaments. So your pelvic joint itself does not allow movement, but it allows the entire body to move. It's not related to the lower limb. You're going to find out more about it in a bit. Now, what is this slide? Why does this have so many words? What's going on? Don't worry about it. The reason I wrote all of this down is because these are the terms that Dr. Faisal Ikram used in his lecture with you. So if you guys have attended his lecture, you should be able to maybe like something clicks that, oh yeah, he said that. So in Dr. Faisal Ikram's slide in your lecture, he mentioned, so if you keep your arms on your waist when you're angry and you stare at someone, the area at which you're keeping your hands, particularly on your waist, is basically the iliac crest. And when you can palpate it, it's the superior spines. And when you can't palpate it, it's the inferior spines. Now, what do I mean by this? I want you to focus on this picture. Now, first of all, these are the pelvic bones. Okay, this is the pelvic bone. Now, this is the anterior view of the pelvic bone, and this is the posterior view of the pelvic bone. Which one of these is, how do I know what part of this is anterior or posterior? It's very important for you to know what plane you're in right now. So let's do that for now. Okay, let's see what plane we're in. Now, this is the pubic symphysis. This will be in the anterior because you have your pubic in the anterior view, right? So this is the anterior part. And what's in your posterior part? The posterior part, you're going to have your ischial spine. We're going to discuss more about it in detail now. Don't worry about it. So do you see your ischial spine here? Yes, this is the ischial spine. This is going to be the posterior part. So over here, this is the pubis, the pubis tubercle. The pubis tubercle is here, but this is the pubis. And this is going to be your anterior because of that. And since this is the ischial spine, this is going to be the posterior part. Now, you're looking at, okay, so this is where I'm going to open my key app for anatomy, which is called VOCA. And we're going to start with this, the pelvic joints, okay? Now, here's what I want you to do. I want you to focus on this side of the page with me. Okay, Bismillah. Okay, I am looking in this picture, in this one, I'm looking like this. Does this look familiar? Does this look almost the same? So the pelvic was like this, and I'm looking at it like this now. So what is this? The pubic, your pubic bone is divided into three parts. It's divided into the iliac or the ilium. This is the ischium, and this is the pubis. Now, why is a bone which is fused together divided into three parts? Because it wasn't always like this. Before you were born, the pubic bone was divided into three parts, and there was a cartilage over here in between. This was known as the triradiate cartilage. Now, what was the importance of this triradiate cartilage? Yes, very good. Bone ossification. So the triradiate cartilage, it ossifies later on in after birth. Now, why isn't it ossified before birth? Because during during the delivery of the baby, the bones of the baby squish and they have to overlap with each other, and there's a lot of friction and whatnot. Imagine if these bones were already fused together. The baby's pelvic would not be compressible. Okay, so you're gonna need to compress the pubis so that the baby can compress the pelvis so that the baby can pass through the birth canal. That's the reason this isn't ossified in the beginning. And another reason it's not ossified is because when the baby is growing, when you grow up from when you were a baby and now, if you pick up a baby, they have a very small waist, right? They're very mobile. So just so our pubic can grow, so our pelvic can grow, these bones are separate. And then when they start growing, then the cartilage fuses, and then finally the pelvic stops growing. Okay? So there's two reasons why you have a cartilage over here first. The first one is so the baby can pass through the birth canal, and the second reason is so the pelvic can grow. Now, this is the ischium. Okay? This is what is this? Guys, what is this? You can't see it from here, but you can see it from the side. What is this? Any answers? So this is the ilium, and this is the ischium, and this is your pubis. Okay? Now, this is the pubis symphysis, which is a connection between both of your pelvic bones. Okay? Now, I need you to focus with me. I'm looking for this picture, I'm looking at it like this from the lateral view. So I can see the anterior superior iliac spine. I can see the anterior inferior iliac spine, and I can see the posterior superior, and I can see the posterior inferior iliac spine. Is that good with you guys? Again, this is the anterior superior, this is the anterior inferior, this is the posterior superior, and this is the posterior inferior iliac spine. And this is the iliac crest. And what is this? This is the acetabulum. This is where the femoral head is going to attach. Okay? And then you have this. What is this now? What is the orientation of this? I'm looking at this. This picture is basically when I'm looking at it like this, from inside. Okay? I'm looking at it from inside, and this is how it would look if I would look at it from inside. Okay? So this is going to be the... Go away. Okay, this is going to be the iliac crest. This is going to be, because I'm looking at it like this, and this one is not for this side. This is for this side. So this is basically, I'm looking at it like this. Okay? This is the right one. This is the right side. So I'm looking at it like this. So this is the ilium, this is the pubis, and this is the ischium. And this is the anterior superior iliac spine, anterior inferior iliac spine. If you go back, you can see the posterior superior iliac spine and the posterior inferior iliac spine. Now there's something called the greater sciatic notch. What is that? This is the greater sciatic notch. This area, this is the greater sciatic notch. There's a better picture of the pelvis. I just can't seem to find it. Okay, I think it's this one. Yes, it is. Okay. Okay, it's not, but it's fine. This is the ischial notch, essentially. Okay? So imagine me looking at it from here. This is going to be the ischial notch. And what is this? What is the significance of the ischial notch? We'll find out in the later slides, inshallah. Now, we discussed what the iliac crest is, the posterior superior iliac spines are. Now, what do I need you to know from this? I need you to know from this that the superior spines, which is the anterior superior and the posterior superior, these spines are palpable. The inferior spines, which were the anterior inferior iliac spines and the posterior inferior iliac spines, these are not palpable. You need to know which are palpable and which aren't palpable because Dr. Faisal Ikram likes to bring low yield stuff. Now, pubic symphysis. Again, we mentioned pubic symphysis. Did we mention pubic tubercle? This is the pubic tubercle, guys. Okay, so this is the pubic symphysis. This would be the pubic tubercle, the bony prominence. Okay. Now, continuing to the... Okay, what's the significance of the pubic tubercle, though? Do you guys remember the inguinal ligament from my previous pal? The inguinal ligament attached to two things. What were the two structures? It attached to the pubic tubercle and the inferior spines would not be palpable. Very good, guys. Okay, so the pubic tubercle would, the inguinal ligament would be connected to the anterior superior iliac spine and to the pubic tubercle. Now, why aren't the inferior spines not palpable? Imagine this. Did you see where the inferior iliac spines were here? They're all the way here. This tiny little thing, this tiny little projection. You see, this is not the above one. The down one, if you can see a light blue color cursor, this is the inferior spine. This is not palpable because it's too inside your body. You can't touch it. You can't feel it. You can't. The part which is more prominent is the superior spines. The inferior spines, they're too deep inside your body, so you can't really palpate them. It's not a conceptual thing, it's just something that is not possible. Okay, for whoever asked that question. You're welcome. Okay. Oops. Okay. Now, we saw the ischial tuberosity. We saw the greater sciatic foramina. I hope you guys understood what the greater sciatic foramina looks like. This, from which you see this muscle. This muscle. Do you see this muscle? The muscle passing through this. This is the greater sciatic foramina. Okay. It's this one. This entire circle. Above the ligament, you have the greater sciatic foramina. Below the ligament, you have the inferior sciatic foramina. And this big thing, do you see this muscle? If you remove this muscle and you remove this muscle, and you remove this membrane, this is the obturator, the big thing. Okay, this is basically this big circle. Okay, and then we've discussed all of this. This is something that I want you guys to focus on. Although Dr. Faisal Ikram did not focus on this in your lecture at all, but we had repeated questions about this in our exam. Our entire exam from pelvis in the MCQs was this. So I need you to know this most importantly and this most importantly. The superior border of the pelvic inlet is formed by the sacral promontory. This is the sacral promontory. Okay? This is the sacral promontory, and it's formed by this, the arcuate line, the line of ilium, the pectineal line of pubis, the pubis crest, and the inferior border is formed by the pelvic outlook, as in the down part, and the ischial tuberosities. We'll get into more detail into it. Don't worry about it. Now again, ilium is the largest superior part of the pelvic bone. Ischium is the posterior inferior part of the pelvic bone. And I'm going to just keep this on the side, just so you guys can keep taking a look. I can keep explaining it on. Yeah, okay. Keep yourself oriented with this. Okay. So the ischium is the posterior inferior part of the pelvic bone. The pubis is the anterior pelvic bone forming the pubic symphysis. The sacrum is the triangular part which is fused. Now, this is what I want you to know. The sacrum is 5 fused vertebrae, okay? If the vertebral spinous processes, do you know how you have transverse processes and you have spinous processes, right? In the vertebra? The spinous processes, because they fuse together, they form this ridge, these button-like things, essentially. Okay, these are the ridges, and these are fused spinous processes. This on the side part, this is the fused transverse processes. This is called the ala, ALA. Okay, you're gonna see it in a bit. Trust. Okay. Now, the iliac crest is used for bone grafting and marrow aspiration. Ischial tuberosity is for fractures. This was not mentioned in the lecture. However, this is something that you will be told later on, inshallah. And the ischial tuberosity is also what you sit on. Now, what is the ischial tuberosity to begin with? You have the ischium. This is the ischium. Do you see this triangular part in the ischium? This is the ischial tuberosity. So this is the pubic part, and this is the greater sciatic notch. This is the ischial tuberosity, or the ischial spine. Okay. Then you have the sacrum. You have the triangular bone formed together. Whatever. So if you have sacral fractures, okay. Do you guys see these? Do you guys see these things? These holes? This is the place from where the sacral nerves pass through. So let's say that you damage your sacrum. What's going to happen? Is anyone texting? The nerves will get damaged, which will lead to... This will lead to the bladder or bowel dysfunction. Paralysis to some extent. Yeah. No problem. But here's the thing. It leads to bladder or bowel dysfunction because the sacral nerves, mainly, they supply the pelvic organs, the ones which are in the pelvis. Okay. And then you have the coccyx. What's the coccyx? This is the coccyx. This teeny tiny bone at the bottom of your spine, that's the coccyx. It's very, very, very sensitive area. And this is, you know how you fall from like if you're standing and you fall suddenly and you fall on your butt, basically, this is what you would damage. It's very painful. Anyways, now, did I mention the obturator? Yes, I did. Remember how I showed you guys that there was something that passes through something, and then you have the muscle that passed through it? Essentially this one, this circle, or this circle, this entire foramina, this entire hole that you guys can see over here, this is the obturator foramina. Now, what's important about the obturator foramina? Do you guys know anything about the obturator foramina? This is the obturator membrane. Okay, the white part over here, this is the obturator membrane. Now, what's important about the obturator membrane is it's something that was formed with birth. Okay, as in before you were born, this wasn't there. You get what I mean? Anyways, that's not important. What's important is you have the obturator membrane, which is covering half of the obturator foramen, which forms, okay, this is the bigger circle is the obturator foramen. The obturator membrane is inside the obturator foramen, and it causes the formation of a small hole, this one. This hole is the obturator canal. So do not get confused between the obturator foramen and the obturator canal. The entire big circle is the obturator foramen. This is the obturator canal. What passes through the obturator canal? The obturator artery, vein, and nerve. Clear? I hope it is. It's between the ischium and the pubis. It's very obvious. Guys, half of the anatomy is based on the parts of the pubis, so you need to know. Now, I'm gonna do this real quick. I need you guys to all answer me. What is this part? What's this part? It's called the ileum. Very good. What about this part? This is the ischium. Perfect. Wow, you guys are really smart, mashallah. And this part? Pubis. Very good. If you know that, you guys are halfway through the lecture already. Okay? The obturator canal is, again, since you guys know where the ischium and the pubis is, you can clearly know that this is the ischium, this is the pubis. The obturator foramen is between the ischium and the pubis. The reason I keep opening VOCA is because I want you guys to visualize how it looks in real life. If you guys don't visualize how it looks in real life, you're going to be confused and you guys are never going to get it. I don't want you guys to memorize all of this. Okay, the pelvic joints. Now you have two types of joints in your pelvic system. First of all is this one, not this one, this one. This is your, what is this joint? This joint is between two bones. It's between the sacrum and the ilium. So it's what joint? It's the sacroiliac joint. Okay? This one is, as I mentioned for the 10,000th time, this is the pubic symphysis. Okay? This is the pubic symphysis. And this is the sacroiliac joint. What's special about the sacroiliac joint? It's a plain synovial joint, and the inferior part of it is fibrous, or else it's plain synovial. Why is it important to know that it's plain synovial? Why isn't the entire joint fibrous? The reason it's not entirely fibrous, if you guys remember, fibrous joints are the ones that which have stitches, right? Right, guys? F&D? Fibrous joints are sutured together. So there is absolutely no movement, or like very, 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 very minimal movement. Am I right? Hello? Yes. And for plain synovial joints, you're going to have some movement. But I just said that you don't have a lot of movement in your pelvic. Now, have you ever thought about moving your sacrum? No, but it moves automatically. Now I'll tell you how it moves. When you're standing and you're going to sit down, imagine yourself standing. Okay, so I'm standing now. And I'm going to sit down. My weight is being transmitted. And my vertebra is now pushing on my pelvic bone. Okay? Now, if there wouldn't be a synovial joint, this bone would be stuck. It would cause friction. It would pain every time I would sit down because there's no fluid here. Synovial joints have fluid in them, okay? If I have nothing over here and it's just bone rubbing on bone, or if it's a completely immobile joint, I wouldn't be able to sit down because there's absolutely no movement. You know what I mean? Now, if I'm sitting down, my vertebrae, my lumbar vertebrae is pushing. This is my pelvis, imagine. My lumbar vertebrae is pushing the pelvis and my pelvis is moving out. When I stand up, I need support again, right? So it's going to move back up. Is that clear or is that too complicated? Definitely. I could tell you another time. No problem. Now, this is me. This is my lumbar vertebra. This is this part. Okay? My back. Okay? When I'm standing and I'm going to sit down, yes, exactly. It acts like a shock absorber for the weight. And the reason that you have a synovial membrane, synovial joint over there is because, let's say it was a fibrous joint. Okay, let's say this is a fibrous joint. If it's a fibrous joint, it's not going to move at all, right? So what I'm saying is the vertebra or the sacrum to the iliac is going to be fused like this. There's no chance of movement. So every time I'd sit down, I can't move my back and relax. So my butt is not going to go like this. I'm not going to move my pelvic at all. Okay? So this is my vertebra, this is my sacroiliac joint, and I'm going to sit down like this, and it's going to have friction every time I sit down because there's no movement. But if I have movement, every time I sit down, the pelvis kind of tilts, okay? Every time I sit down, the pelvic kind of tilts, and then I sit down. If I don't, I'm gonna stop. I can't. Yes, less friction between the bones, so there's more smooth sliding between the joints. Okay, that's the reason you have you have the synovial joint. Okay, but the other one, pubic symphysis, it's a fibrocartilaginous joint. What does that mean? It means, no problem. Please keep the questions coming. I like it. The pubic symphysis, the pubic symphysis is a fibrocartilaginous joint. We don't need a lot of movement over there. Okay. Now, why do we need this though? The pubic symphysis is a flexible joint which moves during walking and birth. I know I said it's a fibrocartilaginous joint, but it's very big. As you can see over here, it's giving you enough space so it would move a bit. It allows slight movement, and essentially during birth you need to make the pelvic inlet kind of bigger, okay, so the fetus can pass through. And this is done by stretching the pubic symphysis a bit because it's a fibrocartilaginous joint. It would stretch a bit, and this would cause a hormone called relaxin to release. Relaxin, guys, is a topic that we haven't taken until now in all of the batches. Do you know what that means? That means that it's going to be in the exam. Okay? So what does relaxin do? Relaxin softens the joints and it increases the mobility by decreasing collagen formation. Okay? So if you have less collagen formation and more collagen degradation, what's going to happen? What's going to happen? You're going to have more movement because it's increasing the mobility by softening your tissues, by softening the joint, by providing more lubrication, more water reception. What does the relaxin hormone act on? It acts on the RXFP1 receptors. Okay. And one important thing that I forgot to mention up over here is that the obturator canal, which was the small one, the obturator artery, vein, and nerve pass through. If, la samahallah, you have a damage or an accident and you end up compressing the obturator canal, what's going to happen? What's going to happen is your obturator nerve is going to get compressed. If your obturator nerve gets compressed, the muscles which it supplies to, which is the adductor muscles of the thighs, you're going to know what adduction is in detail more in your MSK blog, but this is what adduction is. This is abduction, which is moving away from your body, and this is adduction, which is adding to your body. So if you have a damage to your obturator nerve, it's gonna cause weakness in your adductor muscles of the thigh. So getting your legs closer together. Cool? The major pelvic ligaments. Now, very easy. Guys, don't worry about it. This, every joint is stabilized. Where's the receptor on the cartilage? This wasn't mentioned, but obviously it's not going to be on the cartilage itself. It's going to be something which is more internal. The doctor did not mention where it is, so I believe you don't need to know. And again, as I mentioned, this hasn't been taken by the other batches ever in the history of Al Faisal. You guys are the first ones. So they're gonna ask you exactly what's there in the slides and what the doctor has mentioned. And all you need to know about relaxin is that it's relieved during labor to soften the tissues. Why? It acts on collagen. And what does it act on? It acts on the RXFP1 receptors. Cool? That's all you need to know about relaxin. Okay? Now let's move on to the pelvic ligaments. We're already kind of slow. But okay. So this is the sacral. We said this is the sacroiliac joint. The sacroiliac joint, mostly the joints are stabilized by ligaments. So between the sacrum and the ilium, you're going to have the sacroiliac joint, which is stabilized by the sacroiliac ligament. What does it do? It stabilizes the sacroiliac joint. Then you have the sacrospinous ligament. As I mentioned, this is the ischial spine, the one which is protruding over here, right? So this, do you see this ligament? This one? Do you see what it says here? It says sacrospinous ligament. That's what it is. That's the sacrospinous ligament. What does the sacrospinous ligament do? The sacrospinous ligament forms the inferior border of the greater sciatic foramen. Do you guys remember the greater sciatic foramen? You guys know what the greater sciatic foramen is? My intelligent people. Yes. Good. Very good. The greater sciatic foramen's lower border, as you can see over here, ladies and gentlemen, is formed by the sacrospinous ligament. Where is the sacrospinous ligament coming from? It's attaching from, the reason it's called the sacrospinous is because from the spine, from the ischial spine to the sacrum. That's why it's called the sacrospinous ligament. Then you have the sacrotuberous ligament. Now what is the sacrotuberous? This is the ischial tuberosity, the bottom part. Okay, so spine is when it's kind of very pointy, and tuberosity is, it's not too pointy, it's just a little bit flatter. That's a tuberosity. Okay, but it's still it's still prominent, but it's just less pointy. Okay, so this is the ischial tuberosity, the bottom part, and it's connecting the sacrum to the ischial tuberosity. That's why it's called the sacrotuberous ligament. Now, the sacrotuberous ligament is what we sit on. For some reason, Dr. Faisal Ikram kept mentioning what you sit on. So I don't know. You need to know this? Yes. What do you need to know most about this? Is that the sacrospinous ligament helps form the sciatic foraminas, the greater sciatic foramina and the lesser sciatic foramina. The sacrotuberous ligament forms the lower border of what foramina, as you can see from the image? From the image, what do you guys think? It forms the lower border of? That is a very interesting, okay. Not really. Yeah, exactly. But okay, let me just repeat the concept again. This is the pelvic. This is the ilium, the pubis, the ischium. The pubis, you need to know two things. You need to know the pubic tubercle. You need to know the pubic crest, which is this part. Okay, this is the pubic crest. This is the pubic tubercle. And you need to know the pubic symphysis. That's it. Okay. Now, what do you need to know about the ischium? This is the ischium. The lower part, this part, is the ischial tuberosity. Okay. The thing that's protruding is the ischial spine. It makes a part of the acetabulum as well, along with the pubis a bit as well. And then you have the ilium. You have the anterior superior iliac spine. You have the anterior inferior iliac spine. You have the posterior superior iliac spine, and you have your posterior inferior iliac spine. This, if you can see a C shape over here, do you guys see the C shape up? The above C shape is called the sciatic notch. The sciatic notch, along with this ligament, the ligament which is in green right now on your screens, that ligament is called the sacrospinous ligament because this is the ischial spine. Okay, so this ligament forms the greater sciatic foramen. So the greater sciatic foramen's lower border is the sacrospinous ligament. Very good. But what is the lower border of the lesser sciatic foramen? This, you guys, I said, okay, this I said is the greater sciatic foramina. This is going to be the lesser sciatic foramina. Okay. This one over here is the sacrospinous ligament because it's connecting the spine to the sacrum, the ischial spine. This, what is this? What is this location? What is this landmark called? This is the ischial tuberosity. Okay? So this tuberosity is being connected to the sacrum by this ligament. So this is what ligament? This is the come on guys, I'm waiting for you. Sacrotuberous ligament. Very good, because it's attaching the sacrum to the tuberous, to the ischial tuberosity. So what forms the lower border of this lesser sciatic foramen? The sacrotuberous ligament. I hope that clears your concept now. For the ones who are getting confused between which ligament forms the border to what. It's very important for you guys to visualize this. The spine is up, so it would form the sacrospinous, the sacrospinal, what was this? The sacrospinous ligament is going to form the lower border of the upper one. But the tuberosity is down, so it would form the sacrotuberous ligament. It would be the sacrotuberous ligament. Okay? Now, moving on, we have the iliolumbar. This is something that the doctor mentioned. I don't know why he mentioned this, but this is the iliolumbar. Okay? It's attaching the lumbar vertebra to the iliac. Okay? That's the job of the iliolumbar. And the main job is support. That's it. The sacrotuberous is what we sit on. The sacrotuberous ligament is what we sit on. The sacrospinous ligament is what forms the sciatic notch into the foramen, which converts the sciatic notch into the foramen. Okay? Now, the male versus the female pelvises. Guys, first of all, I want you guys to tell me what's the difference between the male and the female pelvis. As in, what would the differences probably be? Female is wider. Very good. Why? Why is there a difference between the male and the female pelvis? Don't tell me what all are the differences. Tell me why is there a difference? Why did God create for birth exactly? Only for birth, only for the process of delivery are both of the pelvics different. Okay? So the male pelvis is more heart-shaped. Why is the male pelvis more heart-shaped? Because they have this thing. Do you see this? Do you see this kind of prominent kind of thing? It forms like a heart and it's kind of prominent. Why is that kind of prominent? It's because that's the sacral promontory. Okay, that's the sacral promontory. And it's more prominent and more inwards or more inverted in the males. But for the females, it's outside. Why? To make the birth canal bigger. And then you have, by the way, this is a very repeated question. We had it on our final as well. They'll show you pictures of two pelvis, okay? And they'll tell you, is A for females or is B for females? And you're going to have to decide whether A or B is for the female pelvis. And it is a heart-shaped and an oval-shaped. Trust. I would show you guys right now. I'll show it to you in the end. The pubic outlet, okay? The pubic outlet is, so imagine this with me, okay? In the males, everything up is inverted and everything down is out. So imagine this. This is how a male's pelvis is, okay? Like ready to fight kind of thing. So it's inverted from here and it's everted from here. And for female pelvis, it's like this. Okay? Now, the reason this is like this way is because, again, for birth, the baby needs to come here and then needs to pass through. Okay? Then you have the weight. The male pelvis is heavier and thicker because you guys love picking weights. And female pelvis is lighter because childbearing again. And the pelvic cavity for the male is conical because it's like this. Remember, it's like this. But for the female pelvis, is cylindrical. When I say cylindrical, it means this part is wide like this. So it's kind of cylindrical. Okay? And the exterior part, the area around it, is going to be cylindrical. Okay? Now, moving on to the focus check. This is a question I need you guys to answer. Please answer it. I'm giving you guys 10 seconds and I'm hoping every single one of the participants answers. There's 3 of you guys. Okay. A 67-year-old thin woman presents to the emergency department with intermittent abdominal pain and nausea for 2 days. She also complains for pain radiating along the medial aspect of her right thigh to the knee, which worsens when she extends or internally rotates her hip. Physical examination shows weakness when attempting to adduct the right thigh. CT imaging reveals a loop of small intestine protruding through the pelvic opening located between the pubic bone and the ischium. Compression of which of the following structures would cause... Okay. C. I'm giving 3 more seconds. 3, 2, 1. Okay, that's news. That's very interesting. The answer is C. And yes, the answer is not A. And the reason it's not A is because the femoral nerve, remember where the femoral nerve passes through? Is it through the obturator canal? No. The femoral nerve passes through the femoral nerve, artery, and vein. They pass through the inguinal canal. Remember? And where's the inguinal canal? Not the inguinal canal exactly, by the way. Sorry, my bad. It passes through below the inguinal ligament, right? The femoral nerve passes through below the inguinal ligament. Remember? We said that the inguinal ligament attaches from the anterior superior iliac spine to the pubic tuberosity. Yes, very good. And below that ligament, the femoral nerve, artery, and vein are going to pass through. But where's the obturator foramen? The obturator foramen is where? It's in the pelvic bone. It's so much down, right? So it wouldn't be the femoral nerve. It's going to be the obturator nerve because it passes through the obturator canal. And I also mentioned that the obturator nerve supplies the adductor muscles of the thigh, right? So all you needed to know is this from the entire text. Okay? When you say difficulty adducting the thigh, it's going to be the obturator nerve. Okay? Now, moving on. This is the pelvic inlet and the pelvic outlet. Do you need to know a lot about this? No. Did Dr. Faisal Ikram stress on this? Yes. But I highly, highly doubt that you can get any questions from this because it's not clinically heavy. But this is the pelvic inlet. Okay? And this is the pelvic outlet. The outlet is going to be the part down. Inlet is up because this way. Okay? Now, in the inlet, you're going to have the sacroiliac joint, which is contributing a bit. You have this part. What did we say this part is? You're going to have the perineal line. You're going to have the pubic line or the pubic crest. You're going to have the pubic tuberosity. You're going to have the sacral promontory. And then you're going to have the same thing on the other side. Okay? The pelvic outlet, you're going to have the coccyx, the sacrotuberous ligament, because it's the one down. It wouldn't be the sacrospinous because sacrospinous is up. And you have the ischiopubic rami. Okay? And you have the pubic symphysis. Now, let's move on to the next one. The pelvic floor muscles. This, my guys, is my favorite topic. Mostly because I get to show you guys how cool VOCA is. And I'm never going to stop flexing that in case you guys haven't realized that so far. But yeah, this one. You're going to see the male, the muscles. The muscles are very important, very high yield. You're always going to get tested on this every year. It's always there. Now, first of all, what the pelvic floor, the muscles of the pelvic floor are collectively called as the, it starts with L. Yes, the levator ani. The pelvic diaphragm. Yes. Yes. Now, this is what the pelvic diaphragm consists of. Okay? You have a fascia first, and when you take the fascia off, you're gonna see the muscles. I'm gonna do hide skin, and I'm gonna do hide organs. Yeah, now we can see only the muscles. Okay, now this is the pelvic inlet. So how am I looking at everything right now? From the top. Let's say that I removed all the organs and I'm looking from the top inside. Okay, this is the posterior part and this is the anterior part. Okay, and you're going to see these. What is this hole over here, the one at the back? This hole is called it's the anal hiatus. Very good. And the one in the front would be your I think it's called the urinary hiatus, the urethra. Yes, the urethral hiatus. Okay, now all of these collectively are known as the levator ani or the pelvic diaphragm. Okay, now let's start from the beginning. Do you remember the obturator foramen? This one. There is a muscle that passes through the obturator foramen. What is it called? It is called the obturatus internus. Do you guys see it? Do you guys see the muscle? The beautiful muscle? It's called the obturator internus. This one is the obturator externus. The obturator internus, it loops around like this. It loops around the obturator foramen. And then you have the obturator externus. Now, you're done with the obturator internus. Where is it? The obturator foramen. Very easy to remember. Then, do you guys remember the greater sciatic and the lesser sciatic foramens? There is a muscle that passes through the greater sciatic foramen. It's the piriformis. Okay? Now, why do you need to know the piriformis? Because there are nerves and arteries that pass through above the piriformis, and there's an artery that passes below the piriformis. The artery that passes above the piriformis is called the superior gluteal artery, and the artery that passes through below the piriformis is called the inferior gluteal artery. Why? Because this is the gluteal region. Gluteus basically means bum bum. Okay, in Dr. Annie's terminology, that's what she calls it. The area of the butt is the gluteal region. Above it would be the superior gluteal artery, and below the piriformis would be the inferior gluteal artery. Okay, the obturatus internus, and now to the bulk of it. These are the muscles. You're gonna see one muscle, this muscle. Do you see how it loops around? It starts from the pubis. Okay, it starts from the pubis and it loops around the rectal hiatus and it comes back. This is called the puborectalis. It's one of the muscles of the levator ani. Okay, so it starts from the pubis. It's the only one, by the way, that starts from the pubis. It loops around the rectal hiatus and it comes back. This is called the puborectalis. Very obvious, just like its name. Now the next one, this one extends from the coccyx to the pubis. So it's attached to the pubis and it goes down and attaches to the coccyx. So what's it going to be called? Pubococcygeus. Simple. And then this one is getting connected from the ileum. Look, from the ileum to the coccyx. They're all attaching here. This is the coccyx. This is the pubococcyx. This is the pubococcyx. This is the iliococcyx. The iliococcygeus is from the ileum to the coccyx. Okay? And then the last one, this is the coccygeus muscle. All right, because it's literally just near the coccyx. Um, these together form the pelvic muscles, the pelvic diaphragm. The puborectalis is the only one that originates from the pubis and slings around the rectal hiatus. The rest originate from the coccyx and go until the pubis. So let's say the pubococcygeus, and then you have the iliococcygeus. They originate from the coccyx. Okay? Now, you have the pelvic floor, the levator ani, the muscles. What are the muscles of the levator ani? Puborectalis, pubococcygeus, iliococcygeus. These are supplied by C3, C4 of the sacral plexus, and coccygeus muscle is supplied by C4, C5. Now, if the levator ani muscles are damaged, let's say that the levator ani muscles are damaged, then you would have weakness, which was called pelvic organ prolapse. Do you know what pelvic organ prolapse means? So when people have weak levator ani muscles, their organs, they drop, and they drop outside the body. So if you have a uterus, the uterus would protrude outside of the body. It would be outside the body. Okay, so you have to tighten these up. You will know how to tighten this up in a bit. Then you have the levator ani. It also helps in the damage would cause urinary or fecal incontinence. It supports the pelvic organs. The coccygeus muscle, it supports the pelvic viscera. Again, injury to any one of these would cause pelvic floor instability. Okay, but mainly for urinary incontinence or fecal incontinence, it's going to be the levator ani. And in your exam, guys, you're not going to get a question, this person is having urinary incontinence. Which of the following muscles is probably damaged or is probably weak? They're not going to tell you, levator ani. They're going to give you one of the names of the muscles of the levator ani. So they're not going to say levator ani in the options. They're going to say pubococcygeus or puborectalis, or they're going to say iliococcygeus, but they're never going to say levator ani. And it's going to be either one of these in the options. That's something that you should keep in mind, because this was also there in the red file. Now, the arterial supply. The abdominal aorta, it bifurcates at L4 level of the vertebra, and then it forms the common iliac artery. The common iliac artery supplies the pelvic organs, the gluteal region, and the perineum, and injury can cause severe pelvic hemorrhage. The superior gluteal artery, where did we say the superior gluteal artery is? Guys, I mentioned it. Remember? Who remembers? Piriformis, very good, above the piriformis. Well, you guys already know the lecture. Now I'm just doubting. Are you guys here just for funsies? But thanks, you guys are very smart. Helped me feel really great about myself. Okay, so the superior gluteal are above the piriformis. The inferior gluteal nerve is below the piriformis, and these are both derived from the internal iliac artery. And then you have the internal pudendal artery, which is also from the inferior gluteal artery. Now, this is something that I need you to know, that I want you to understand with me. There is common iliac. It gets separated into external iliac, internal iliac. The external iliac then passes through the front and forms the femoral nerve, the femoral artery. Where does the femoral artery pass through? Below what? What is the landmark? It passes below one ligament. What is the name of the ligament? Very good, the inguinal ligament. Very nice. So the femoral artery is coming from what? The external iliac, which is coming from the common iliac. Now put that to a side. Let's come to the other part of the artery. You finish the common iliac artery, you're moving on to the internal iliac artery. Now, the internal iliac artery gives three branches. It gives the obturator artery, which passes through the obturator. So the internal iliac will come from here, and it will go here, and it will start supplying the obturator artery. It will give one branch called the obturator artery. The second branch it will give will be the superior gluteal, which will be above the piriformis, and the third branch will be inferior gluteal, which will be below the piriformis, and it will give one last branch. Okay, it's going to give the internal pudendal artery. Do you guys remember the internal pudendal artery? If it clicks, I think you guys took it in GIT. I think it was my lecture in GIT. Yes, very good. Thank you guys. So the internal pudendal artery, it goes outside the pelvic diaphragm from the sciatic foramen, and it comes back through the lesser foramen. So what is it doing here? What is it doing here? Guys, the pelvic diaphragm is, do you see how the pelvic diaphragm is over here? Okay, it's like a bowel and it's kind of up. Okay, so the pudendal artery is essentially leaving from this foramen, the greater sciatic foramen, this one, and it's passing through from outside. It's gonna go outside and it's gonna go down, down, and it's gonna supply from here. Because remember what the internal pudendal artery supplied? It supplied your anal canal, right? You guys see the internal pudendal artery? It's the one in green, and it's going down, down, down. You see how it's going? Wait, it's the one it's the one in light green. It's the one in light green. It's a lot of, ugh, I'm gonna have to hide all of it. Okay, anyways, but it's, do you see how it's not going from like directly, right? If you guys can, where is it gone? But essentially it's going from inside the foramen. I'm trying to dig deep, but this is what your body really looks like, guys. Yeah, it's gonna go from these. It's gonna go from this foramen. It's gonna go through this, and then it's gonna go behind it. It's gonna go behind it somewhere over here, and then it's gonna go from outside the foramen, and it's gonna take a loop, and it's gonna come back. It's a very cool app, guys. I love Voca. Next up, oh, this is just a review. So what passes through the greater sciatic foramen? You have the sciatic nerve, the piriformis, the superior and inferior gluteal vessels. So if you have the greater sciatic foramen is compressed, what is it going to cause? Sciatic nerve compression, which causes sciatica. Lesser sciatic foramen, if that is compressed, then you're going to have pudendal nerve block. Okay, no significance really, but the pudendal nerve block is usually given for anesthetics. So you inject the anesthetics in the pudendal nerve for labor. And then you're going to have the internal pudendal and the obturator internus, which is through the, wait, the obturator internus is not in the lesser sciatic foramen, guys. This is a typo. Where's the obturator internus? It's in the obturator canal with the obturator nerve and the vessels. Okay. Next, you have the venous supply of the blood of the pelvis. This is very simple. This wasn't even mentioned, honestly, in your guys' lecture. But essentially, it's the internal iliac vein, which drains the pelvic organs, and the pelvic venous plexus, which drains the bladder, rectum, and the prostate. Okay, and this is the way for the tendon leaves via the lesser sciatic, though it, if yeah, the tendon, it loops around the lesser sciatic foramen. Yes, you're right about that. But the obturator internus, the muscle itself, because I mentioned obturator internus muscle, I guess. I didn't mention anything. But the obturator internal muscle itself is through the obturator canal. The tendon would loop around through the sciatic foramen, through the lesser sciatic foramen. Okay? But if they ask you, where is the obturator internus, the muscle, it's on the obturator canal. Okay? Okay. This is something important. The pathway for cancer metastasis is through the pelvic venous plexus. Okay? Then you have the anatomy of delivery. Okay, now this took me time to understand. Inshallah, I should be able to explain to you guys in really easy words. Again, this is something that wasn't taken by any of the previous batches. This is taken first time by you guys. Henceforth, it's going to be in your exam. Okay? Now, you're going to see the fetal head. It's in random positions. But when it's time for birth, it starts diving down. And the head is placed laterally to your back, essentially. So if this is my back, the baby's head is this. It comes like this. Okay, it's like this in the beginning. The baby comes down like this, and it's facing to the back of its head is on my back. And then the pelvic muscles, they start acting. They start contracting, relaxing, contracting and relaxing. This causes the baby's head, which was like this, to flex towards its neck. This is flexion, by the way. So it's getting the head near the neck. Now, what is the point of doing this? The head now, which was over here, is gonna bend like this. What's over here? If this is my back, and lower posterior inferior, no sorry, anterior inferior, you're gonna find what? You're gonna find the vaginal opening, which is perfect because that's where the baby's supposed to push through, right? So this is where the baby's head would be located, and then you start pushing. Okay, and another reason why why flexion of the baby's neck, of the flexion of the baby's head is very important, is because imagine if the baby's head is extended like this, it's gonna block the birth canal. Imagine the baby's coming down, and his head goes like this, not like this, goes like this. So how's the body gonna come out then, right? So this is another reason why you need to understand the pelvic structure muscles working, because the flexion of the baby's head is very important. And then finally, the puborectalis relaxes and stretches several times. Relaxin is released, everything happens, and then the baby is finally delivered. You have also something called Kegel exercises, which is again what we hadn't taken in the past. So it's going to be in the future, which means you guys, very lucky batch. So what's going to happen? Think of it this way. You're training all the muscles that you need to control you from either passing gas or releasing urine. Okay? So if you're going to hold your gas in, what are you going to do? You're going to contract a few muscles down there. And those muscles, although I'm laughing really hard internally right now, but we should be professional as medical students, you contract muscles, okay, down there, and you do it unintentionally. But because of damage to, let's say, the pudendal nerve or to your pelvic floor, you're going to lose the strength or the ability to keep these muscles contracted. Okay? So you perform the Kegel exercises, which help you, and there's two types. You have delayed contraction and relaxation, and you have repeated contraction and relaxation, which is very fast. And this improves the urinary control. It's used to prevent pelvic organ prolapse. So remember how I said that sometimes the uterus just falls out. The uterus falls out of the vagina sometimes after birth. This is called uterine prolapse, if I'm not wrong. And one of the treatments for this, yes, you can do surgery, but a less invasive method is through the Kegel exercises. Okay? And it's used in rehabilitation therapy. Oh, it's also used. So do you guys know how you remove the prostate cancer? So after prostate cancer, after treatment of prostate cancer, you have urinary incontinence. You guys took that, remember? In renal. So if you have prostate cancer and you do the treatment or you remove the prostate completely, you're going to have urinary incontinence as a male. Now to treat this, you're going to use Kegel exercises. Okay? The reason I'm mentioning prostate cancer again and again is because it was also here for a cancer metastasis. It would be the pelvic venous plexuses. Now this is the last question for you guys, and then you guys are free to go. I'm going to count until 10. 9, 8, 7. Oh wow, mashallah. All right. Oh, I just realized I kept the answer as C for both of them. Okay. But you guys didn't know that. Okay. So you guys are absolutely right. It is C because inferior to the piriformis muscle through the greater sciatic foramen is the inferior gluteal artery. That is it from my side, guys. Thank you very much. Please scan the form. Give me feedback. I really need it. Maybe I wasn't clear with my words a few times. Please feel free to contact me and ask me questions if you want to. And you can ask me questions now as well if you want to. True and false pelvis. Okay, true and false pelvis. This is first of all, this was just one slide in your lecture, and the reason I skipped it is because he didn't stress on it, so I didn't stress on it. But the thing is, true and false pelvis is basically above the pelvic inlet is the false pelvis, and below the the pelvic inlet is the true pelvis. That's pretty much it for true and false pelvis. You have, what do you have in the true pelvis? You have the pelvic organs, you have the levator ani, you have all of this. But there's nothing, it's nothing very significant. Is it very clinically significant? No. And Dr. Faisal Ikram, FYI, gets only clinical significant questions. If you want to know anything, just if you think that it has a clinical relevance, know it. If it doesn't, you don't need to know it. Yes, one of you are asking for the app. What about the app? The app is called Voca. It's for free for the first year. And after that, it's minimal charge. So I still use it because Voca, yes, Voka. Voca. Voca Anatomy. It's the perfect app